Going to be the third video in a series of 4 that covers your reproductive information for your 114 content. So the postpartum period is going to be the time from delivery until the body returns to its pre-pregnancy state. So that's typically about 6 weeks. You should know, just for frame of reference, to be completely back to what we consider normal takes longer than that, but we typically consider the postpartum period delivery up until about 6 weeks, sometimes a little longer depending on what's going on with the patient. So one of the main things that you need to focus on when looking at your postpartum content as far as studying is to be very well versed in the postpartum assessment. So this is not going to take the place of a normal head to toe. This is going to be in addition to that normal head to toe. So you would still do your normal head to toe assessment, Q-shift, just like you would on a med-surg unit, but what you're going to be doing is adding in components that are specific to the reproductive system. So you can use the acronym BUBBLE-HE to kind of make sure that you're hitting all the areas that you should be assessing, but we're going to talk about these individually. So breast, uterus, bladder, bowels, lochia, episiotomy/perineum, checking to see if they have hemorrhoids, and if so, making sure we're doing nursing actions related to that, and then evaluating their emotional reaction to labor, because that can have some differences or some things that we need to be mindful of. So you will not do every one of these things with each vital signs check, but you will do a lot of these. So when we ended the last video, we were talking about that vital signs are going to be checked really frequently in that postpartum period, because the first 24 hours they're going to have higher risk for complications and those type things. So when we're looking at that, this is also when you're going to add in some of these specific things. So along with your vital signs in that Q15 times 4, Q1 hour times 2, that sequence that we talked about at the end of the last video, you're also going to want to assess the uterus, the lochia, and the perineum. So with every vital signs check in that sequence, you're going to add those 3 things in. The other parts of the postpartum assessment are just checked frequently or as needed. So let's talk about these. So these are not going to be in the same order as the BUBBLE-HE, because I wanted to pull some of them out separately and then talk about your uterus and stuff together. So alright, so bowels, breast, and bladder. You want to educate your patients about breast care, and there is a difference between breastfeeding moms and non-breastfeeding moms. So a mom that is breastfeeding, that is going to require us to assess the breast more carefully, especially while, after they're breastfeeding, to make sure there's no cracks in the nipple, and that the nipple contour is consistent with being able to have the baby latch on properly. So with a breastfeeding mom, your breast assessment becomes very important, because if the baby is not latching on properly, they can have some soreness, they can have some cracks, and the nipple contour does play into whether or not the baby can latch properly. So most patients are going to have an everted nipple, which is easier for the baby to latch, but if they have a somewhat flat nipple, that's going to be harder for the baby to latch on. So we would need to get involved and offer some different techniques and some different things that could help with that. If your mom is not breastfeeding, then your care is completely different. For a breastfeeding mom, we want to support that breastfeeding option. But for your non-breastfeeding moms, it's extremely important that we give them measures to help prevent their milk production from coming in. So non-breastfeeding moms, we're going to tell them to bind their breasts. So either wear a really tight-fitting sports bra, even when they're in bed, or they can do an ACE wrap, like if they forgot to bring a sports bra and they don't have anybody that can go get it, or it's COVID-19 and nobody can come in the hospital kind of thing. We can use an ACE wrap as well to help bind the breast. That just helps to prevent their milk from coming in, which will help with pain and engorgement. The other thing that we need to tell our non-breastfeeding moms is that when they are showering, they need to shower with their back to the jets of water, because the warm water will actually cause their milk to let down or to come in. So we want to make sure they shower with the warm jets of water to their back and not with their breast to the warm jets of water, because that'll help also. The term engorgement is just a term that means that the breast has gotten engorged with milk. It can be very painful, and it's going to predispose them to developing mastitis, which we're going to talk about a little bit later. As far as bowel and bladder function, so we'll do bladder function first, especially if they had an epidural. When we give someone an epidural, It's going to numb their bladder, so they're not going to have the sensation of needing to go to the bathroom, so their bladder can become over distended. And what you should know is that a full bladder is going to displace the uterus, which is going to increase the uterine bleeding that they can have. So a full bladder can actually predispose them to having a postpartum hemorrhage. So we want to make sure they're emptying their bladder. If they have a spinal because they're having a C-section, there's typically a Foley catheter left in place while that spinal is causing that numbness. But for an epidural, we typically try to get the Foley catheter out before we start pushing. So it is possible that a patient with an epidural can develop a full bladder postpartum, and we either need to, get them up and let them go to the bathroom, or if needed, we can do a catheterization if they cannot void. But a full bladder is definitely not something that we want. You also want to assess the bowel function. A lot of our patients, or really all of our patients, are placed on a stool softener just because of the close proximity of where they just pushed a baby out. That whole area tends to be really sore, and so we don't want our patients straining to have a bowel movement and that causing even more pain for them. And when we talk about the perineum assessment, there's some things that can happen, like as far as lacerations to the perineum, that we most definitely need to place those patients on a stool softener, but I'll cover that when we cover those specific ones. You also want to assess for hemorrhoids so that we can, give them comfort measures like witch hazels or medications that help to prevent the discomfort. Hemorrhoids are extremely common during pregnancy. They're even more common in the early postpartum period because they just pushed a baby out, and that pushing stage can last for up to 2 hours. So if they were already predisposed to having hemorrhoids, it is very common to see that in the early postpartum period. So we want to make sure that we are providing them with some comfort measures to help with that. As far as emotions, there's a couple things I want to discuss. So all of our patients are screened for postpartum depression. We'll ask them a certain set of questions on admission, and then we will also screen them 24 hours after they've been admitted to the hospital. So we'll screen them for postpartum depression or any history of other types of depression, because if they have a history of, I hate to say normal depression, but if they have a history of depression outside of pregnancy, they are still more likely to have postpartum depression. So that's important. So usually when patients come in the hospital, we just ask them, have you had any history of postpartum depression or mental health issues that we need to be aware of while you're here in the hospital? So just kind of taking that stigma away from it. It happens, and we want to make sure we provide them with good support systems and get medications started if we know that's going to be something they struggle with. The screening at 24 hours is a little bit more in depth, and it's something that the postpartum nurse would go over with the patient to make sure that we're not identifying anything that could be a red flag. The kind of catch-22 on that is a lot of times when we start to see postpartum depression is going to be outside of that 24, 48-hour, or even 72-hour window that they would be in the hospital. So a lot of your hospitals have decided to also do a callback and screen them at home. So that's also a good thing. A lot of times the true postpartum depression issues don't start to exhibit symptoms until they are at home, which can be very problematic because the patient may not want to or may not even realize that they need to seek help for that. So good education about the fact that, if they are starting to have issues, they need to report that to someone. So I do want to briefly discuss the differences between baby blues, postpartum depression, and postpartum psychosis. So baby blues is pretty common, and it's not something that a patient necessarily needs to seek treatment for. It's something that we need to be mindful of. So the way I teach students to recognize baby blues versus postpartum depression, baby blues, yes, you may be emotionally kind of all over the place. You may be very upset at times and okay at other times, but you're still getting up, you're still doing for yourself, you're still doing for the baby. So you're completing your ADLs and the baby's ADLs. That's kind of baby blues. Postpartum depression is going to be when those coping mechanisms are not there and you are no longer able to care for yourself or your baby. So there's times where you just can't function to get those ADLs done. That would be more a sign of postpartum depression. So some of the education that we can do during that discharge planning for a postpartum patient would be to say, okay, if you're getting up and you're doing things for you and the baby and you just feel a little sad, that's one thing. But if it gets to the point where you can't take care of yourself or the baby, that most definitely needs to be reported to the healthcare provider so that we can get some medications going. And I know that you guys have not had your mental health lecture yet, but typically it takes about 2 weeks for antidepressants to really kick in and for the patient to get some good benefit from that. So the sooner they start to have symptoms and report that, the sooner we can get that medication on board, the sooner they're going to start to feel better. Postpartum psychosis is a weird variant that you typically see make the news. It's the ones where the moms harm themselves, commit suicide, or they murder their child. So that is a very extreme form of postpartum depression that we typically do not see. However, there are some changes emotionally that are acceptable and normal, and everybody pretty much goes through these. So your normal responses that you'll typically see is going to be taking in, taking hold, and letting go, which probably doesn't mean anything to you right now, but I'm going to kind of go over that for you. So with the taking in, that's what we usually see in the immediate postpartum period after delivery, and they want to relive their experience. They want to tell everybody about how horrible it was and how much pain they were in. They may let others do for the baby, so they may not be actively involved in changing the diaper. That's okay as long as they progress to the next stage. Taking hold, they start to do for the baby. They need lots of encouragement. We need to assess them for postpartum depression issues during this period of time. So don't just assume that everybody knows how to diaper a baby. And if you go in the patient's room and they've diapered the baby and it's completely backwards, don't make a huge deal out of it. Just, show them the correct way to do it and be very supportive in your teaching methods. The third stage is going to be letting go. And this is where they reorder life. They feel more comfortable in their role of being a parent. So this is kind of what you'll see at the end of the hospitalization or on into them going home. Everything's kind of been reordered and everything is more in a normal state for them. We also want to make sure that bonding is occurring. So there's some kind of telltale signs that we can look for. So if you have a mom and she's in the bed and the baby stays in the cradle all the time and she doesn't hold the baby, she doesn't talk to the baby, those should be red flags that bonding is not really taking place. And that can be a huge issue in the postpartum period and then sending them home. We want to make sure that we're sending these babies home to a very loving, safe environment. So those red flags would need to be reported, and we can get social services involved if needed if we're seeing that the bonding is just not taking place. So signs of bonding are going to be talking to the baby, holding the baby, taking care of the infant, especially if they're holding them face to face and talking to them. That's a huge sign that bonding is taking place. So is the mom taking care of the baby? Make sure that you look at other areas where the emotional impact of a pregnancy may be harder. So if you think about single parents, adolescent pregnancies, if they had twins or triplets, there's just not enough hands to care for the amount of infants, and that can predispose them to a lot of postpartum depression issues. If they don't have a family support system, if their baby was a stillborn and they're not going to be able to take the baby home, or if the baby was premature and the baby's going to require some extensive hospitalization. So all of those types of scenarios are going to require a little bit more support and kind of making sure that we don't have any depression issues that we need to deal with. Okay, one of the major things that you're going to assess in your postpartum period is going to be the uterine assessment. So I'm going to go over what's on this slide and then we're going to talk about it a little bit more. So if you see the term involution, that is the normal process of the uterus returning to its normal size and location. So remember, the uterus is supposed to be very small. It's supposed to be a pelvic organ, but because it had to house a baby and amniotic fluid and a placenta, it became an abdominal and sometimes almost a chest organ because it had to grow so big. So it does have to shrink back down to be able to be displaced back into the pelvis where it should be. So that is involution. If it is not occurring like it's supposed to, we call that subinvolution. So involution would be normal. Subinvolution is going to be abnormal. It's not contracting and shrinking down in size the way it should be. So we've talked about the fundus at every stage of pregnancy. It's very important, but it's important for different reasons. When we talked about the fundus in the antepartum, we were doing fundal heights and looking for fetal growth. When we talked about fundus in the intrapartum period, we were talking about where to place the toco and assess for contractions. In the postpartum period, we are checking to make sure it is shrinking down like it should. So typically right after delivery, so right post-delivery, it should be somewhere at or slightly below the umbilicus. So right after delivery, it should be slightly lower or right at the umbilicus. That would be your normal finding. It should be firm because remember the uterus is a muscle, and a muscle contracted should feel firm, just like when you were palpating for contractions. If the uterus is clamped down, because it should be, because it's actively trying to shrink, then it should be firm. And it should be midline, so it should be located in the middle of the abdomen. So post-delivery, normal findings, fundus should be firm, it should be midline, and it should be at or slightly below the umbilicus. So your abnormal findings would be if it was above the umbilicus, if it was soft, and we call that a boggy uterus, kind of feels like a squish ball, or if it's deviated to the right. So I'm going to talk about what each one of those would mean. So typically, if it is above the umbilicus significantly, that usually indicates that the uterus is not clamping down like it should, which is probably going to lead them to bleed more, which is not something we want to occur. If it is soft, it is not contracted. So we need to do something to make sure that it does contract. And if it is deviated to the right, that usually indicates a full bladder. So if it's deviated to the right, you need to empty the bladder and then reassess to see what we have, if it's still boggy or deviated, that kind of thing. So normal findings would be that the fundus is firm, midline, at or slightly below the umbilicus. And that should continue to decrease by 1 centimeter or 1 finger width per day. So by postpartum day 3, they should be about 3 centimeters under the umbilicus or 3 finger widths below the umbilicus. For your abnormal findings, that's going to be boggy, which means soft, deviated to the right, which indicates a full bladder, or located above the umbilicus. No matter which one of those 3 you have, there's got to be an intervention that you do to correct it. So you'll notice in the picture on the bottom, it's showing you how to assess the fundus. So remember, the fundus is an organ that's shaped kind of like a light bulb. So you'll notice that the healthcare provider is placing their hand pretty much where the lower uterine segment would be, pretty close to the symphysis pubis, and they're applying counter pressure there so that you don't inadvertently invert the uterus and push it through the vagina, because that is not a good day. That is not what you want to do. So you want to provide some lower uterine segment pressure, or just kind of some counter pressure there, and then you're going to take your other hand and starting around the umbilicus, you're going to feel down until you feel the fundus. And the fundus should feel, if it's nice and firm, should feel like a softball sitting up under the skin. It's really easy to feel for most patients in that early postpartum period. So counter pressure over the symphysis pubis, you're going to palpate the fundus, and that's how you're going to do your assessment. So if it is boggy, you're going to massage it. So again, you're going to put counter pressure over the symphysis pubis, and then you are going to massage the top of the uterus from the outside the body, obviously, to make it contract, because if you massage it, it should start to contract and tighten up and get hard. If it's deviated to the right, you're going to empty the bladder first and then reassess the fundus. If none of that works, then you're going to need to administer medications to help contract the uterus. So we mentioned a couple of these earlier. So one of the things that you're going to want to give is Pitocin. That was the drug that we use for induction of labor, but it can be used in the postpartum period at a bolus rate or at an increased rate to contract the uterus down. So oxytocin or Pitocin would be one of the medications that we could administer to help contract the uterus. And then we also talked about some of the others that were used for postpartum hemorrhage. Those are the same medications. So your Cytotec and your Methergin would also be drugs that could be used to clamp the uterus down. Along with the uterine assessment, so typically what we do is we would pull the cover back, and along with the uterine assessment, we would also be assessing the perineum to make sure that everything looks appropriate there. So one of the things that you're looking for is lochia, and lochia is the normal discharge that you see post-delivery. It goes through 3 phases, and so while they're in the hospital, we typically see lochia rubra, which is kind of a dark red, bloody, kind of fleshy smelling discharge. So it kind of smells like menstrual blood, but it should not have a foul odor or anything like that. So it's a very fleshy smell, but it's not a malodoriferous smell, so it doesn't have a foul smell to it. So rubra is going to be the first one that they're going to go through, and then after they leave the hospital, that's probably going to quickly change to lochia serosa, which is more pinkish to brownish discharge. And then the last stage of discharge is going to be the lochia alba, and that can occur for a pretty good period of time during the postpartum period. So typically they're only going to have that lochia rubra for about 3 to 4 days before they see some change in it to a serosa type discharge. So if they are having lochia rubra at 2 weeks postpartum, that is not normal. Alright, so the amount, so we don't just look at what type of discharge they're having, but we also look at the amount that they're having. So I always tell students it's kind of testing versus what we do in practice. We don't typically take a ruler in there and, measure how much blood they have on their pad, but for testing purposes, we need to give you some type of concrete measurement to be able to tell you how much bleeding they're having. So I'm going to cover both of those. So I'm just going to cover what's normal and abnormal, and then we'll talk about what that means. So normal bleeding is going to be scant or small. A moderate amount of bleeding is okay in certain circumstances, but not every circumstance. But your abnormal findings would be a large or a copious amount. So let's talk about that. So scant means there's just a little bit of a smear on there. So if you look at that picture there, it talks about scant being a 1-inch stain on the peri-pad. Your light or small, if you look on there, it says a 4-inch stain on a peri-pad. Your moderate is going to be 6, and then your heavy is going to be saturating a peri-pad within an hour. So I always say this with a little caveat. So if you have a patient and you go in and you put on a clean pad on them, and 15 minutes later they've saturated a pad, you're not going to wait till an hour has passed to decide they're having too much bleeding. So that's just saying that they should not be saturating a whole peri-pad within an hour. If they're saturating a peri-pad in 15 to 30 minutes, that is definitely not normal. The term copious just means there is no doubt this patient is having a hemorrhage, they are bleeding out. So copious is never normal. So scant and small is okay. Moderate is okay in certain circumstances. So let me talk about what circumstances we would tolerate that. So let's say that you have a mom and she has had 3 previous deliveries. So this is her 4th delivery. Then her uterus has been stretched more than a first-time mom. And so her bleeding may tend to be a little bit heavier because that uterus is going to have to work harder to contract back down to a pre-pregnancy state. So if they've had several deliveries before, or this is a delivery of a large baby, or this is a delivery of multiple babies, those patients tend to have a little bit more bleeding, and we will be a little bit more tolerant of that. But if this is a first-time mom who's never had a baby before, they really shouldn't have moderate bleeding. Now, obviously, their bleeding is going to be relative to how often I change that pad. So if they saturate a peri-pad, but they've had that peri-pad on for 6 hours, that's not a big deal. So just kind of take into consideration the whole information that's provided in the scenario when you're looking at different test questions. Okay, so treatment for this. Let's say that we checked our patient and their fundus was deviated to the right and their bleeding was large. Then we're going to empty their bladder. We're going to reassess the fundus and reassess the bleeding. If their bleeding is still large, then we need to do fundal massage, oxytocin. If that doesn't work, you're going to add on different medications. So really what you're finding in your uterus assessment should correlate to what you're seeing in your perineal assessment. So if the findings are normal on the fundus, then there should be normal amounts of bleeding. There is one caveat to that because there's always little extra things in nursing. So when you look at bleeding, so let's say that you assess the fundus and it was perfect. It was firm, it was one below the umbilicus, it was midline, everything was perfect. But then when you pulled back to look at their perineum and their bleeding, you just have this constant trickle of blood. So what that can indicate is a cervical laceration. So the cervix is extremely vascular. So if it is lacerated when the baby passes through it, the fundus can be doing its job just fine and clamping down, but the cervix itself could be what's bleeding. So normal uterine findings with a constant trickle of blood needs to be reported immediately to the physician, because we can give oxytocin all day long, but we can't fix that cervical laceration. That has to be done by the healthcare provider. So constant trickle with normal uterine findings needs to be reported to the physician. Other things that you would report to the physician is a large amount of bleeding, a copious amount of bleeding, a moderate amount of bleeding in a first-time mom that's not getting any better. So the abnormal findings are the ones that you're going to report to the healthcare provider. Okay, so along with your uterine assessment, your perineal assessment as far as bleeding, you're also going to look at the actual perineum of the patient. So there's two things that can happen or that may be seen with a delivery. So they can have a laceration, or the healthcare provider could actually perform an episiotomy. So a laceration is a tear to the perineum, meaning they tore on their own. An episiotomy is a surgical cut to the perineum. Both of those are going to make a little bit more room for the baby. One's just a controlled surgical cut versus allowing the body to tear on its own. That's really physician preference. Sometimes it's even patient preference. We do have some patients that come in and say, my body's made to have babies. If it tears, it tears. That's just what I want to happen. So it really does depend on the patient and the situation and the physician as to whether or not there will be an episiotomy performed. But it does allow for a little bit of extra room to allow for manipulation and for the healthcare provider to get the baby out safely. But not everybody has to have those, and not everybody has a laceration. It just depends on the patient. There are two types of episiotomies. There's a midline and a mediolateral. If you look at the picture on the top left, it just shows you the position of those cuts. So a midline is straight down, so from the perineum down towards the rectum, and a mediolateral is going to be from the perineum in the middle, kind of to the side. That is also physician's preference. We just record it with whichever method they decide to cut. All of these are going to be given degrees 1st through 4th. So whether it's a laceration or an episiotomy, we're going to gauge it 1st through 4th. Or I say we, the healthcare provider is going to tell us which one it is. So a 1st degree, so there's two pictures on here to kind of show you, because you almost have to understand that the degrees are not only distance between the vaginal area and the rectum, but it's also deepness of that laceration or episiotomy. So if you look at a 1st degree, it is extremely superficial. They are extremely common. They're easily repaired. They don't really cause any issues for the mom. A 2nd degree is also very common. It's a very common episiotomy to be performed. It's also a very common laceration that we see. It's a little bit deeper into the structure, but it's still a very common, easily repaired area. So 1st and 2nd degree, pretty common. We don't really worry that much about them. They're easily repaired. When we get into some problems, it's going to be your 3rd and 4th degree. So your 3rd degree is going to be that they usually, because we don't typically cut an episiotomy this far, so they may have cut a 1st or 2nd degree episiotomy that then tore into a 3rd or a 4th degree laceration. So a 3rd degree is going to be from vaginal opening down to the rectal sphincter, but not through it. So that's a very important distinction. So a 3rd degree, so typically if they think they have a 3rd or a 4th degree, they're going to do a rectal exam at the end, because they need to know if that sphincter is intact or not. So a 3rd degree is going to be from vaginal opening to the rectal sphincter, but not through it. A 4th degree laceration is going to be all the way through, so all the way from the vaginal opening down through the rectal sphincter. So with this patient, they have an opening that can allow fecal matter into their vaginal tract. It's a much more extensive repair, both the third and the fourth degree. There is an unbelievable amount of swelling that usually happens with those. So for those patients, if they have a third or fourth degree laceration that has to be repaired, we typically will place a Foley catheter because the swelling can be so extensive that it prevents them from being able to void. So it's very important that we take care of going ahead and placing a catheter if we feel like they're not going to be able to void. You're going to assess a repaired episiotomy or laceration just like you would any other wound. So you're not going to have a dressing on it, so you're going to assess breath, so bleeding, redness, exudate, approximation, size, tenderness, and swelling. So you're still going to do that same assessment on an episiotomy, it's just in a different location. You're also going to want to assess the perineum for hematomas. So hematomas are things that you've seen before on patients. They can also get those in their vaginal area. It's very vascular, and so if there's a blood vessel that starts to bleed, what you'll usually notice with these, it's going to look like a swollen, bruised area, and it's almost always going to be unilateral. Very seldom do we see hematomas form on both sides of the labia. So when they deliver, it's important to know what they look like post-delivery, so that every 15 minutes or 30 minutes, however often we're assessing that we can tell if that is getting larger, because you can have a pretty substantial blood loss into a hematoma, which can cause them to be hemodynamically unstable just because there's so much blood in this hematoma. Now, the perineum of a patient post-delivery can be very swollen. So just generalized swelling is something that we accept, but if there's an area that looks bruised and swollen or is increasing in size, that needs to be reported to the healthcare provider. You're also going to assess hemorrhoids during this time. Now, hemorrhoids may not be something that you assess every single time you do a fundal assessment on the patient, but it is something that you need to check on a frequent basis. The easiest way to look at the episiotomy or laceration and to assess for hemorrhoids is going to be a side-lying position with their leg up, so the upper leg can be bent up. It's an easier position to get patients into, and it allows you to see that area completely. So that's a good position to put a patient in to do a thorough perineum assessment. The treatment for the swelling and the discomfort that we know is going to happen because of having a baby or having an episiotomy or laceration, we would use, just like for a sprained ankle, you're going to use ice for the first 24 hours. That helps to decrease the amount of swelling that they have. And we can also use medications like Dermaplast or Epifoam, which is a spray or a foam that's applied to the perineum and has some anti-inflammatory properties and is very soothing to the patient. So a lot of times we'll spray them with Dermaplast or put the Epifoam on an ice pack, because those two things together do a lot to help with comfort and swelling. After the first 24-hour period, we can switch from ice to heat. So the heat helps to vasodilate and promotes healing of that area. So ice for the first 24 and then heat after that. They can also start doing a sitz bath. So if you'll notice in the top right upper corner, there is a sitz bath. So the pink part actually sits in the toilet. The big bag is filled with really warm water, and it's kind of like a portable bidet, for lack of a better way to put this. So that warm water kind of runs front to back over their perineum, and that's very soothing to them, but it also helps to decrease risk of infection also. We also have to teach our patients about perineal care and what they should do. So regardless if they have an episiotomy or not, some of the things are going to be very similar that we teach them. But most definitely if they have an episiotomy, they need to be doing this. So they'll get a little squirt bottle. Every time they go to the bathroom, they need to fill it up with really warm water. They need to wash their perineum from front to back, always front to back, never the other direction. So they're going to wash front to back. They're going to pat dry, and we want to make sure that like toilet tissue and things like that doesn't get stuck to those sutures that are going to be there. The good thing is those sutures are going to dissolve, so they're not going to have them taken out, but we still don't want little pieces of tissue to get stuck to those sutures, because I kind of just think of it as a very small petri dish that just collects the yuck and they can get an infection. So most of the time what we will tell them to do is to take a bath cloth and to pat dry with a bath cloth instead of the tissue. They can just put the bath cloth into the dirty hamper. It's going to be sterilized, and then we don't run the risk of having tissue that's stuck to a suture line. So peri-care is going to be with every void, warm water, front to back, replace their peri-pad front to back, and then make sure they pat dry so that the area is nice and clean and dry. All right, so we already talked about your perinatal care. Postpartum care is a lot about education. So is your newborn care when we talk about it. So we want to teach them signs and symptoms of complications, which we're going to cover on the next slide. We're also going to go over birth control methods with them. So for some patients, when we talk about sexuality, we'll talk a lot about birth control. But for some patients, it's going to be they want to have a tubal ligation. That's a more permanent form of birth control. We do have some patients that opt for the depot shot or the birth control pill, or maybe they don't want anything for birth control. So we want to make sure that we go over and address their birth control options, because it can happen. If they're having sex in that first 6 weeks postpartum, they can absolutely get pregnant in that time frame. So we want to make sure we're offering birth control options. And just so we're completely clear on this, breastfeeding in and of itself is not a birth control method. So we do have patients that can get pregnant while they're breastfeeding. Teaching about breastfeeding versus non-breastfeeding. So some of this will be covered with your newborn lecture, but for your breastfeeding moms, they need to know that those babies are going to tend to eat more frequently. So they will eat on demand. So usually they eat about every 2 to 3 hours versus your non-breastfeeding or your formula-fed babies that eat about every 3 to 4. So there is a little bit of a difference there. And we've already mentioned the care of the breast for a breastfeeding mom versus a non-breastfeeding mom. We also want to make sure we go over nutritional guidelines for them. So just like when we talked about them in antepartum, if they are breastfeeding, they're going to need to continue that increased caloric intake of 300 to 500 calories per day from nutritional sources. They need to make sure they eat a well-balanced diet that's high in iron, because obviously there was some blood loss. And I don't think I mentioned this in the earlier slides, so let me mention that now. The normal blood loss for a vaginal delivery is going to be between 3 and 500 milliliters of blood. So for a vaginal delivery, we typically consider a normal blood loss 3 to 500 milliliters. Versus a C-section, we typically consider a normal blood loss for those patients to be 700 to 1,000. So 3 to 500 for a vaginal, 700 to 1,000 for a C-section. And when we do the case study in the afternoon session, I'm going to tell you how we can actually quantitate that blood loss and be a lot more specific in measuring that. So 3 to 500 for a vaginal, 700 to 1,000 for a C-section. So we know they had a significant blood loss, so we want to make sure they have good iron intake. And we also tell them to continue their prenatal vitamins as long as they're breastfeeding. So somebody that's not breastfeeding needs to continue their prenatal vitamins during that 6-week postpartum period, but a patient that is breastfeeding needs to continue taking their prenatal vitamins until they stop breastfeeding. It just kind of gives them some extra nutrients and a little bit of extra support. The other thing we need to make sure that we tell our breastfed moms is that you are what's supplying the milk for the baby. So things that makes mom's stomach upset tends to also make baby kind of gassy. Broccoli is a great food, and it's definitely going to be something that's nutritious, but if they're noticing that their baby is a little bit more fussy or gassy, they need to kind of take stock in what they've been eating, because there are certain foods that cause gas in the mom that are also going to tend to cause gas in the baby. As far as activity restrictions, for a vaginal delivery, the biggest thing is going to be no sex or anything per the vagina until they're cleared by the physician, which is usually 4 to 6 weeks postpartum. They can start to increase their activity, but one good rule of thumb is if their rubra turned into serosa and then all of a sudden it turns back into rubra, they're probably doing a little bit too much. So making sure they're providing for adequate rest periods and not overexerting themselves, but we do want them getting up and moving around. If they've had a C-section, there will also be some weight restrictions as far as lifting. So typically we tell them not to lift anything over the weight of the baby, because babies are typically not going to be over 10 pounds, definitely not over 15. So they can lift the baby to be able to provide care, but they shouldn't be mopping or straining or doing any heavy lifting until they're cleared by the physician. Some complications that we can see in your postpartum period, mastitis is one of them. Mastitis is going to be an inflammation or infection of the breast itself, or the duct of the breast. Signs and symptoms of that are going to include redness. There's usually a swollen kind of mass area. It is usually unilateral. It's very uncommon to have bilateral mastitis at the same time. They usually have a fever greater than 100.4. and they may have pain when they're breastfeeding. So it is an infection, so obviously it's going to be treated with antibiotics. One of the misconceptions that we see with our breastfeeding moms, because they are more likely to get mastitis, because typically after the milk suppression has been, or after the milk production has been suppressed in your non-breastfeeding moms, they're not likely to actually develop this. But your breastfeeding moms, because they're continuing to breastfeed, are usually going to be the ones that have issues with mastitis. One of the misconceptions is that you should stop breastfeeding. That is something that's an individual basis. So the new recommendation, or the current recommendation, it's not really new. The current recommendation is if there is no abscess in the breast, then they should continue to breastfeed on that side, because it's going to clear that duct and help the healing process. If there is an abscess, they still need to empty the breast, but they would need to do that by breast pump and discard that milk, which is horrible to have to tell a breastfeeding mom, because it really is a lot of work to breastfeed, and it's like liquid gold. So to tell them they have to pump and dump is kind of, sometimes can be very heart-wrenching for them. So if there's no abscess, they can still safely breastfeed on that side. If there is an abscess, they will need to pump the breast and then dump the milk. It will be treated with antibiotics, and it should improve pretty quickly. For your hemorrhage, most hemorrhages that we see are going to be what we would consider early hemorrhages, and usually happen within the first 24 hours post-delivery. And this could be because the uterus is not clamping down, or they have subinvolution. It could be because of a full bladder that wasn't treated. It could be because there was a cervical laceration, or it could be because they have a hematoma. So something is going on. That would be an early hemorrhage. So for a vaginal delivery, if they have a bleeding episode after delivery and they're anything that totals an amount greater than 500 is going to be considered a postpartum hemorrhage for a vaginal delivery. However, it is possible to have postpartum hemorrhages up to 6 weeks postpartum, and that's usually because the uterus isn't clamping, or there was a little portion of the placenta that didn't deliver, and that's preventing the uterus from clamping down, and that can cause a late postpartum hemorrhage. So we want to make sure that when we do our discharge teaching for our moms, we tell them if they start to experience heavy bleeding, they need to report that to the physician. Infection is also a very real possibility in the postpartum patient, and it can be a variety of locations. So it could be mastitis, because that's an infection, but it could also be a uterine infection. It could be an incisional infection if they had a C-section. It could be an infection of the perineum where they had an episiotomy or a laceration. So the signs and symptoms are slightly different, but a lot are the same. So I'm going to go over that. So with anybody that has an infection, fever needs to be reported. Any foul-smelling discharge, so vaginal discharge, discharge around the sutures, discharge from the incision. Of course, and even with mastitis, if there's an abscess, there actually could be discharge from the breast. So any foul-smelling discharge needs to be reported, and obviously we would treat those with antibiotics, ranging from outpatient with oral antibiotics all the way to inpatient with IV antibiotics, depending on the severity. One thing that I do want to mention, just because it is a little bit weird in the postpartum period, so typically, obviously, if we do lab work on a mom after delivery, we expect that her H&H is going to drop some because she had a blood loss. That is a typical finding. We still worry about really low H&Hs, but what you might not think about or even realize could be a possibility is that your postpartum moms tend to also have an elevated white blood cell count that can be a completely normal finding for them. So with your postpartum patients, if we happen to draw a white blood cell count, and let's say she delivered today and tomorrow morning we draw a white blood cell count, it is not abnormal for that white blood cell count to be elevated, which would typically tell us if there's an infection, but it's actually an expected finding in your postpartum patient. So if you have a postpartum mom with an elevated white count and there's no other signs of infection, it is probably just a normal variant and an expected finding. However, if you have an abnormally high white count and they're running a fever, or there's foul-smelling discharge, or the area is really red and inflamed, that is going to be more likely to be an infection. So just kind of look at the whole picture when you're trying to interpret that. So one of the symptoms that you could see of an infection would be a increased white blood cell count, especially after they leave the hospital. We've already talked about postpartum depression and baby blues and how we screen for that on admission and 24 hours later. But we want to make sure that at discharge that we go over, what they need to do if they start to feel overwhelmed, like they may be having some postpartum depression. We also know that your patients are going to be at much higher risk for DVTs and PEs because as a preparation method, the body had more clotting factors on board, anticipating that they were going to have some blood loss. So signs and symptoms of a DVT you've already learned about. You probably, I can't remember if PE is in 113 or not, but I'm going to go over what the signs and symptoms are. So DVT is going to be unilateral redness of the calf is usually where you would see a DVT, although you can see it other places. And then a PE, the biggest symptom that you're going to see is hypoxia and chest pain. A lot of times your patients, when they experience a PE, are going to say they have a sense of impending doom, like something bad is going to happen. We also want to tell them to report chest pain, not only because it can be a sign of a PE, but there are certain patients that are higher risk for developing cardiomyopathy and heart issues, which could be indicative, or they could be experiencing some signs and symptoms of heart failure. So any chest pain or chest discomfort needs to be reported. Because when you have a baby, you've pushed this big baby out of a small hole and you've used a lot of muscles, it is not uncommon to have issues with stress incontinence post-delivery. So one of the things that we tell patients to do for that is going to be to do Kegel exercises. So when they're in there and you're doing your good, postpartum teaching and you're teaching them how to do perineal care and how to use the water bottle, it's a good time to go ahead and teach them about Kegel exercises, because what we would tell them to do is when they're sitting on the toilet and they're urinating, to stop their flow of urine. If they stop their flow of urine, they're using their Kegel exercises. So they're using the muscles they need to help prevent or decrease the amount of stress incontinence that they have. So that's a good way to be able to teach them so that they understand it. If they can stop their urine flow, that is a Kegel exercise, and they can do that while they're sitting on the couch or breastfeeding the baby, whatever they need to do. All right, common medications. So there's a lot of medications that can be given in the postpartum period. So there's this slide, and then there's a ton on the next slide. So I'm just going to hit the high points of these because it looks like a lot, but I promise it's not that daunting. A lot of this we've already talked about. So Benadryl and Nubane. Nubane is actually a pain medication, but we do have patients, you'll see straight across from that, the term Duramorph. So for your spinal patients, we typically give them something in their spinal to give them some long-lasting pain relief. A lot of hospitals use a drug called Duramorph, which is an extended-release morphine that's injected directly into the spinal. Any of your narcotics, however, can cause itching, but for whatever reason, your intrathecal narcotics tend to cause more itching. So here's kind of the caveat with that. If they had a Duramorph spinal and they're itching but there's no rash, they're not allergic to it. It's just a side effect. If you have itching and a rash, that is an allergic reaction. But to kind of help counteract that, we can give Benadryl or Nubane, which sounds counterintuitive. The Benadryl makes sense because it's an antihistamine. The Nubane is actually an antagonist with the Duramorph, so it kind of counteracts it slightly. So the Nubane is kind of our backup drug to help with itching from a Duramorph spinal. Simethicone is Gas-X. We have a lot of our C-section patients especially that have a lot of gas pain, so it's just Gas-X to help with the gas pain. Stool softeners like Colace or Senecot are commonly used, but will definitely be used if they have a 3rd degree or a 4th degree laceration. We may use a variety of antibiotics depending on what's going on with the patient, but Ancef is one of the most common ones we use. So when we talked about your C-sections and the fact they would get a pre-op antibiotic and then a post-op antibiotic, that is typically Ancef unless they are allergic. And just remember, your Ancef is a cousin to your penicillins. So if they have a penicillin allergy, they're more likely to have an Ancef allergy, so watch that closely. So if they have a penicillin allergy that's anaphylactic, we probably would not give Ancef. But if it's a penicillin allergy with a rash, we can give Ancef and see how they do. A lot of patients can take it. I have a penicillin allergy. I can take cephalosporins like Ancef with no problem. So just make sure you check allergies on that. We'll continue their prenatal vitamins with the same teaching that we talked about in your antepartum period. We mentioned your ROGAM in your antepartum about blood testing and your negative blood types on your mom. So for the postpartum period, remember they get it at 28 weeks during the antepartum period because we don't know. So that's going to be for all negative blood types. Post-delivery, they'll get a dose within 72 hours if the baby is a positive blood type. So if mom is O negative and baby is O positive, mom gets a ROGAM shot. If baby is O negative and mom is O negative, then we don't need to give that postpartum dose of ROGAM. It is a blood product. It is given IM. So you may or may not need to give that, but you would need to know circumstances where you would or would not give it. Rubella vaccine also talked about in your antepartum period. So if they are rubella immune, then they do not need a rubella vaccine. If they are rubella equivocal or non-immune, then they are going to need to get a rubella vaccine postpartum. It is a live vaccine. It cannot be given during pregnancy, and they do not need to get pregnant for at least a month post getting that vaccine, which they shouldn't be having sex anyway because they shouldn't be having sex for 4 to 6 weeks postpartum. They also shouldn't be douching or doing any kind of tampons during that period either. We do promote that parents get a pertussis vaccine now. So pertussis is the whooping cough vaccine, and the mom has probably already had a pertussis vaccine. However, your baby does not get a pertussis vaccine until a little bit later in their vaccine schedule. And so by giving mom and dad and grandparents, if they're going to be taking care of the baby, by giving them a pertussis vaccine, it prevents them from getting pertussis that they could then transfer to the baby. So the reason we support that is because it gives almost like a herd immunity to that household. So it prevents them from getting pertussis, which probably wouldn't be a big issue for them, but that could be life-threatening for that baby. So it helps to give the baby some protection from that. Durmorph, long-acting morphine given intrathecally through a spinal. Your Anaprox is going to be an NSAID. It's kind of like souped up Aleve. It's like a prescription dose of Aleve. Your Percocet is a narcotic. It has a narcotic and Tylenol in it. Ibuprofen, everybody knows that's an NSAID, but Caldolor is the IV form of that. So if you see that, that's IV ibuprofen. Works fantastic for our patients. Tylenol, everybody knows. Ofirmiv is the IV form of that. So there is an IV Tylenol as well. We already mentioned the Epifoam and the Dermaplast. And then Toradol is going to be another NSAID that can be given post-delivery for pain control. So a couple things I want to go over. So you would not want to have a patient taking Anaprox, ibuprofen, and Toradol. That's a little bit overkill on the NSAID spectrum. And we do know that NSAIDs can tend to cause a little bit more of a bleeding issue. So you would also not want to give those to patients that are hemorrhaging or having heavy bleeding. However, they're perfect options for patients that need pain control but do not want to take a narcotic or don't want to be sedated because they're trying to breastfeed, or maybe that are even concerned about taking a narcotic because they are breastfeeding. Your Percocet, those type drugs, Percocet, whatever the hospital uses that you are going to, you'd be in doing clinicals, all of your narcotics are going to carry the same risk they would that you've talked about for semester after semester now. So just remember the Percocet does have Tylenol in it, so you would also not want to give Percocet on top of Tylenol because you're going to max out on your daily amount of Tylenol that they can have. So those should not be given together either. So in the hospital setting, a lot of times what we get is this massive order and it has all these drugs on it, and it's kind of our prerogative or our responsibility to make sure that we're doing that in an effective manner. So you don't want multiple drugs being given in the same category. You don't want to max them out on Tylenol, and you want to make sure that you're respectful of their wishes as far as what type of pain medication they would like to get. And this is just labels of all of your lovely drugs that we've already talked about. Okay, that's going to be it for your postpartum lecture.